Hello, everyone. Thank you for joining. My name is Jay Patel, and I'm one of the Interventional Cardiology Fellows at Vanderbilt University Medical Center. And here with me is Dr. Jared O'Leary, one of our faculty interventional cardiologists. And today I'm going to present a unique TAVR case, which is a valve-in-valve TAVR case. We have no financial relevant relationships with commercial interests to disclose today. So we'll dive in, and our case presentation is a 66-year-old female who basically presented with shortness of breath and symptoms that were consistent with heart failure. She has a history of bicuspid aortic valve and ascending aortic root aneurysm, for which she underwent a 23 millimeter magna bioprosthetic valve replacement, along with the ascending aortoplasty approximately 10 years ago, which was performed at an outside hospital, and we did not have full operative reports for. And so as you can see here on the panels on the right, this top left video shows a parasternal long, shows normal mitral valve function, as well as normal LV function. And then the video on the right shows color Doppler, which shows very mild mitral regurgitation, as well as mild aortic regurgitation and some turbulence with the outflow there. And then on the bottom right, you see a apical four chamber, which shows normal biventricular function and size. And then here on the bottom left, you see a aortic valve continuous wave Doppler tracing, which shows a Vmax of 4.7 meters per second and a mean gradient of 54 millimeters of mercury, and a overall DOI of 0.214. So overall, with her echocardiogram, which kind of shows normal biventricular size and function, well-seated bioprosthetic valve with severe stenosis based on all of the criteria, which include the mean gradient being above 40, peak gradient being above 4, as well as a DOI being less than 0.3. And her RVSP, right ventricular systolic pressure, was 42 millimeters of mercury. She underwent a CT for procedural planning, as well as a CT angiogram, which showed calcified proximal vessels without any obstructive disease. And again, she did not have any known coronary disease prior to begin with. And her CT showed adequate peripheral vasculature for femoral approach for a valve-in-valve TAVR, and a slightly enlarged aortic, ascending aortic root, which was about 4.7 centimeters. So we underwent a multidisciplinary approach, and after a team discussion, we felt valve-in-valve transcatheter therapy would be the best for this patient based on prior sternotomy and STS score. So she presented for a valve-in-valve TAVR. Unfortunately, we had difficulty crossing with the valve system through her previously placed bioprosthetic surgical valve due to combination of interference with the prior prosthesis, as well as her aorta having a very horizontal takeoff. So initially we tried multiple manipulations, including using a stiffer wire along with various rotations of Evolute system, which were all unsuccessful. Following this, we also tried doing a bioprosthetic valvuloplasty using a 16 millimeter Tyshak balloon. And here on this video on the right, here's the valvuloplasty using the Tyshak balloon, inflating and then coming back down. But again, it still did not provide adequate valvuloplasty to allow the surgical valve system to be delivered into the left ventricle. So then we shifted our gear to using a Snare technique, which has been previously described by Naganuma and colleagues in Catheter Cardiovascular Interventions Journal. And so as you can see here on the right, I've kind of outlined her aorta, which, as you can see, has a very horizontal takeoff. And so what we did here was we removed the wire after the valvuloplasty from the left ventricle, then used a 25 millimeter gooseneck snare and placed that into the ascending aorta. And this is here the snare that's in place. Subsequently, used a AL1 catheter and a straight wire to advance the safari wire through the snare. And it's very crucial, of course, you have to go through the snare system to be able to lock on and use the snare to help delivering the system, as we'll see a little bit later. After crossing the snare, or after crossing into the snare, used again the AL1 catheter and a straight wire to cross through the bioprosthetic aortic valve into the left ventricle. And in this place, we used a extra small safari wire through the snare into the LV. And after this, we were able to deliver the Evolute R system, which was advanced over the safari wire and through the snare. And then as you can see here, the snare is placed at the very distal tip. And then the snare was tightened and pulled tight across to help straighten out this aorta from a very vertical, to help it align better with this horizontal aorta. As you can see, initially it was the snare, or the delivery system itself is very vertical, not allowing it to pass through the horizontal bioprosthetic aortic valve. But the snare was pulled along the inner curvature of the aorta to facilitate a more coaxial alignment and crossing of the bioprosthetic valve. And subsequently, we were able to successfully deploy a 26 millimeter Evolute R valve, which was deployed in the standard technique with overall excellent angiographic results. And as you can see here on this image on the right, this is a post image after the Evolute valve was deployed with the delivery system still in place. So subsequently, the patient did very well, tolerated the procedure well, was discharged in a very stable condition on postoperative day number 2. She presented at a 6-week follow-up, at which time she was overall completely asymptomatic with a transthoracic echocardiogram showing very stable transvalvular gradients. And so this is a very unique case. So one of the questions I wanted to pose to the audience was, with the valve-in-valve TAVR, has been associated with which of the following? Valve-in-valve TAVR has been associated with elevated post-implant gradients, i.e. Patient prosthesis mismatch. It has been, option number B, it has been associated with elevated coronary artery occlusion risk. Option number 3, it is associated with increased risk of valve thrombosis. Option number D, difficulty crossing the previous valve with a wire. Option E, which is difficulty crossing the previous valve with the TAVR delivery catheter. And option F, which is all of the above. Give you a couple of seconds to think about it. And so the answer actually is all of the above. Valve-in-valve TAVR does have an increased risk of increased gradients due to multiple prostheses being in there, as well as patient prosthesis mismatch at times. Also associated with elevated coronary artery occlusion risk due to the multiple leaflets that are present there. Also associated with increased risk of valve leaflet thrombosis. And as you saw from our case, associated with both difficulty crossing the valve with the wire itself, as well as associated with increased difficulty with crossing the previous TAVR with the delivery system itself. So this case uniquely identifies the importance of having a detailed evaluation with preoperative CTA, careful procedural planning, and knowledge of techniques for valve crossing and coronary protection as needed on an individual case-by-case basis. So procedural planning in this situation would really help identifying the horizontal nature of the aorta with the other prior prosthesis in place, giving you a elevated heightened risk that you may need to use a snare system or various different techniques that could be utilized to help cross the valve successfully. In this case, we showed you this unique Snare technique that was described by Naganumo and et al. And colleagues. So overall, be familiar with increased and procedural difficulties associated with valve and valve TAVR system. Thank you for your time, and I appreciate you guys listening.